Hi, this is Brian Kim. I'm going to share with you case number 233 in the Best Way to Do Cataract Surgery series. And the purpose of this title is not to suggest this is the best way, but to get you to think about your best way to perform cataract surgery, which means scrutinizing your cases, looking at your videos, and seeing how you can refine and improve your techniques so that you can provide the very best for your patient. So this is a hypermature cataract, and you're going to see the use of Trypan blue. And I'm going to perform terminal chop and cross chop to efficiently disassemble the lens. And terminal chop helps to avoid the posterior plate phenomenon and being able to tackle this very dense lens. So I use a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size the rhexis. You can see this lens looks rather dense. I'm using the cotton tip to steady the eye and make a corneal incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. The cotton tip is important to help me control the eye for each of these maneuvers. This is intracameral epinephrine and then intracameral air. And you want to really kind of burp the aqueous out and then put some more air in. Just pushing a little bit more air here. And this is the Trypan blue. I'm making sure I paint the anterior capsule surface. And I'm just sweeping side to side to allow that dye to cover the entire anterior lens capsule surface. This is some dispersive viscoelastic, pushing the dye and the bubble out at the same time. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready to enter, I turn the eye towards me with the cannula and I go in. These are the sharp tip microforceps. I like to do this two-handed technique, especially with a dense lens like this, in case there's some cortical milk that comes out. I puncture the center. I have the viscoelastic cannula ready to flatten the capsule if I need to. Luckily in this case I don't have much milk. As I puncture the center and I pull towards me, I grab the right edge of the tear to create a flap going around circumferentially. Again, using that cannula to help control the eye and pushing viscoelastic if I need to. I'm ready there just in case. And these low profile forceps are really nice, and the teeth of the forceps open nice and wide, which is really nice as well. Finish off the rhexis. Burp some viscoelastic out. And this is a Capsulorhexis hydrodissection technique. I'll place a cannula under the rhexis edge contra-incisionally, point the tip down. You can't see the wave, but of course there is a wave, and then the lens begins to spin. Again, in my experience with these dense lenses, hydrodissection is not as important. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuchal material, turning the bevel up now, switching to the dense mode, and I'm going to start sculpting. So I'm sculpting in preparation for terminal chop. Again, with terminal chop, this is essentially a modified stop and chop technique. But with stop and chop, you're trying to crack the surface, so you have to really get really deep with stop and chop. I don't think that's necessary because with this technique, I'm going to place the chopper around the lens equator. And since I'm going to fracture the lens from the terminal side, I immediately am able to fracture the lens through and through, thereby avoiding the posterior plate phenomenon. So in my opinion, this is a safer and more efficient way to crack a very dense lens. The lens is rather loose, so I go ahead and just turn it in 180 degrees, and I'm doing some more sculpting. You can see, again, I'm not going all the way down to the posterior capsule, which again is not really necessary. I turn the bevel back down, and I'm ready to crack. Go to quad mode, sliding the chopper under the rhexis edge contra-incisionally, hook the peripheral lens, fracturing the lens. You see that the chopper is at the lens equator. I'm down and deep at the same horizontal plane as the thickest part of the lens. The phaco tip is also deep within that trough. I'm flanking the peripheral lens with the instruments, and then I'm going to fracture the lens, pulling the chopper towards the phaco tip. It fractures the lens peripherally, but those same lamellar fibers, as I crack, the lamellar fibers are getting propagated and fractured all the way through and through, going from the distal side all the way to the proximal side. And I place the chopper around the right heminucleus, hooking the peripheral lens from the lens equator. The phaco tip is deep in the trough, flanking the right heminucleus, pulling the chopper towards the phaco tip, crushing the lens against the phaco tip. And now I have completely separate two pieces of the right heminucleus. Getting around the first quadrant with the chopper, crushing the lens between the instruments, and then emulsifying the lens pieces. Again, a very efficient way, an easy way to disassemble this hypermature lens. Positioning the second quadrant in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it essentially toward the phaco tip, which is deep within the bag, fracturing the lens. Again, all the fracturing is done without any vacuum or ultrasonic energy. And I'm using the phaco tip not as the phaco emulsification handpiece, but really as a second chopping instrument. And the phaco tip is really acting like a chopping block. Turning the second heminucleus in front of me, placing the chopper around the lens, hooking the lens from the equator. Again, I'm positioning the phaco tip deep in the trough. Both instruments are flanking the densest part of the lens, again, at that same horizontal plane. Again, the chopper is at the lens equator. The phaco tip is flanking the lens on the other side, pulling the chopper toward the phaco tip and crushing the lens against the phaco tip, breaking that heminucleus in half, doing the same thing with the lens around the third quadrant. And you just keep executing the same cross-chop maneuver. Again, crushing the lens between the instruments, and then when you're ready, emulsifying the lens pieces. By doing it this way, I'm reducing the use of ultrasonic energy as well as vacuum. I have a much more controlled situation. Reduced use of ultrasonic energy in this manner has afforded me clearer corneas postoperatively as well. And of course, clearer corneas means less damage to the corneal tissue. Eating up that third quadrant and then positioning the fourth quadrant around, placing the chopper around the lens, crushing the lens completely in half. And notice all those bubbles that are essentially stuck to the viscoelastic, which is coating the corneal endothelium. This again is another sign that I have very good coating of the corneal endothelium. Those bubbles are a reflection that I have good protection, and therefore I will most likely have a nice clear cornea at the end of surgery. Lifting that fragment up with some vacuum, crushing the lens with the chopper, crushing the lens into smaller and smaller pieces, and then emulsifying the lens pieces. And when you have a lot of lens pieces still in the bag, I don't mind keeping my phaco tip deep, keeping it away from the cornea. And even though I'm starting to activate ultrasonic energy and vacuum, it's okay to initiate ultrasonic energy and vacuum because I have a lot of lens material that's protecting the posterior capsule. Once that lens material is gone. You have to be much more mindful about the phaco tip and protect the posterior capsule as much as possible. And that's why I use that chopper to protect the posterior capsule. So this is the last piece. It's stuck in some of the viscoelastic, very carefully, grabbing it with some vacuum and then emulsifying it. And that's it. That's all the lens material that's gone now. A small fragment at the incision. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, removing the cortex from anterior to posterior. You can see there's just some wispy cortical material there. I'm just going around removing that wispy material. I don't have any really large sheets of cortex here, just some wispy areas of cortex. Polishing under the rhexis edge, polishing the posterior capsule as well. The polish mode is really very effective and really a safe way to efficiently remove some of the stubborn lens material. I'm removing some of that subincisional material with the polish mode, but once I grab a big chunk of it, then I switch to cortex mode, remove that lens material, and then switch back to polish mode. So you can kind of toggle between polish mode and cortex mode depending upon what you need in that moment, and I'm doing this with foot pedal control. Pulsing BSS into the subincisional capsule fornix. Filling the bag with cohesive viscoelastic, first turning off the infusion, because if you don't turn off infusion, all you're going to do is cause the viscoelastic to come out of the wound, which makes no sense. So turn off the infusion and then fill the bag with cohesive viscoelastic, polishing with the sweeper first on the left side and then the right side, and you want to remove any potential cortical material as well as the lens epithelial cells. I'm going in with the Li61AO lens. You want to keep the injector position the way it is, straight up and down. You really don't want to rotate it. The haptic will swing as it comes out. It's going to swing towards the right, but then it's going to swing back. This is a push style injector. You want to be very mindful. Very slowly let the haptic come out. As it comes out, it's going to go into the bag. In this case, it didn't swing and it just went straight in, but sometimes it does swing. In this case, it just went straight into the bag, which is totally fine. The trailing haptic did not go into the bag. I used the viscoelastic cannula to just reposit the trailing haptic into the bag. Go underneath the lens with the INA handpiece, removing all the viscoelastic from within the bag. And this is a nice thing. This is the smaller injector for the Li61AO lens. You can see with the pink sleeve, this is for my 2.4 millimeter incision, and it works very well for that small incision. Again, in some cases, the leading haptic swings, interestingly enough, with the Li61AO, but in this case, it did not, which was fine. And again, you want to utilize a very slow injection with this plunger style injection. Thankfully, the leading haptic went right into the bag, and then I just dialed the trailing haptic in. You can see a nice clear cornea at the end, removing all the viscoelastic and then hydrating the incision. So again, this is terminal chop, cross chop. Terminal chop, the purpose is to debulk the dense central core of this hypermature lens, and then placing the chopper around the lens equator, and then placing the phaco tip deep, and you're essentially flanking the terminal aspect of the lens material that's towards the lens equator. By fracturing it from the terminal side, you're able to fracture through and through all the lamellar fibers of the lens. And by doing so, I'm able to fracture and propagate that fracture through the entire corneal lamella from anterior to posterior. And by separating the lens fibers, you get this natural propagation of that fracture point through and through, starting from the distal where you're fracturing all the way central and then subincisional, going all the way across. A nice and efficient way to divide this very dense lens and avoiding the posterior plate phenomenon into two heminuclei, and then performing multiple cross-chop maneuvers, again, essentially positioning the chopper around the lens equator, pulling it centrally toward the phaco tip, which is, again, on the other side of the lens, flanking it, crushing the lens with repeated fracture forces, and then emulsifying the lens pieces. You can see, even though I used quite a bit of ultrasonic energy, I had great coating of the cornea, as been shown by those bubbles that were trapped in the viscoelastic. And therefore, this lens, even though it was a very dense one, the patient will have a nice clear cornea postoperatively and have an amazing visual experience after surgery. So I hope this was helpful to you, and I thank you for your attention.